The ilioinguinal iliohypogastric nerve block is one of a series of truncal fascial plane blocks for the lower abdomen and is generally used to cover incisions in the inguinal region. Unlike the rest of the innervation of the abdomen, the ilioinguinal and iliohypogastric nerves originate from the L1 nerve root and are branches of the lumbar plexus. They emerge from the lateral border of psoas major, run over the anterior surface of quadratus lumborum, and continue traveling on the deep surface of transverse abdominis muscle. Both nerves only enter the plane between transversus abdominis and the internal oblique, the so-called tap plane, in the region of the anterior third of the iliac crest, at a point anterior to the mid-axillary line. As a result, they may not be consistently covered by lateral or posterior tap blocks and should be specifically located and targeted. Key anatomical points to note, therefore, are that the nerves are located very close to the anterior superior iliac spine, the ASIS, just cranial to it in the tap plane. A line drawn between the ASIS and the umbilicus will intersect these nerves as well as the T12 nerve and is a useful surface landmark for placing your ultrasound probe. The other critical point to note is that the external oblique muscle turns into an aponeurosis inferior and medial to this line and will appear as such when scanning with ultrasound. While the ilioinguinal and iliohypogastric nerves initially lie in the tap plane close to the ASIS, there is a huge amount of inter-individual variability in exactly where the nerves ascend to pierce the abdominal wall muscle layers and emerge into subcutaneous locations. Certainly at some point inferior and medial to the ASIS, the ilioinguinal nerve will leave the tap plane and pierce internal oblique to lie on top of it, where it will be covered only by the external oblique, which is itself an aponeurosis and not a muscle in this area. This explains the many different landmark-guided techniques that have been described over the years, all of which involve an injection point medial to the ASIS and usually inferior to it, but differing in the tactile endpoints that are recommended. It is an appropriate technique if ultrasound is not available, but based on my understanding of the anatomy, I would recommend piercing the skin to enter the subcutaneous tissue and then seeking just a single pop, which should signify penetration of the external oblique aponeurosis. Injecting a large volume here, for example 15 to 20 mL in the adult, should produce spread to both nerves wherever they enter and run within this plane. This single pop technique also reduces the risk of excessively deep penetration, which can occur if double pops or deeper blocks are sought. If scanning to locate the ilioinguinal and iliohypogastric nerves, however, start by identifying a surface landmark line between ASIS and umbilicus. Place the ultrasound probe close to or against the iliac crest, parallel and superior to this line. You will see the dropout shadow of the iliac crest and 3 layers of muscle: external oblique, internal oblique, and transversus abdominis. The nerves will be located in the plane between internal oblique and transversus abdominis, close to the iliac crest. More medially, the pulsatile ascending branch of the deep circumflex iliac artery may be seen, and medial to that, the T12 nerve. Note that if the probe is placed inferior to the ASIS umbilicus line, the external oblique muscle will have turned into an aponeurosis and there will no longer be 3 muscle layers. In addition, the nerves will be ascending out of the tap plane to lie superficial to internal oblique and are much more difficult to spot and target. It is therefore critical to always place the probe cranial or superior to the ASIS umbilical line. Use a medial to lateral approach and inject into the tap plane between internal oblique and transversus abdominis. This video illustrates this. Here we have started by targeting the T12 nerve more medially. Note that piercing fascia with a block needle can be difficult and result in a lot of tenting. Use tactile pops to help identify entry into the fascial planes. Subsequent hydrolocation will confirm appropriate spread. To target the ilioinguinal and iliohypogastric nerves, move the probe more laterally and inject into the tap plane closer to the iliac crest.